So hi, thank you all for walking over here. You could have stayed like dry and comfortable at the library, so thanks for being here. So I'm Rhonda Thissen with DBHDS, and that's our acronym for those of you using APA style. We've already defined our acronym, so we're DBHDS. So yes, I want to talk with you today about an initiative that we have that we're working on from the state level in 8 communities around the state. Let me just get a read of who's here. So how many of you all are service providers or practitioners? So some people. Primarily substance use or also mental health? Both? Okay, good. What about academics? Okay, a few, great, okay. And anybody else, state people? I know we've got DMAS is here, hi. So great, so we want to talk a little bit about an initiative that we have going on for transition age youth and young adults. So we're working with youth ages around 16 to 25, some maybe a little bit older. And so these are our youth and young adults that are experiencing their first episode of psychosis, so precursor or potentially diagnosis of a schizophrenia, schizoaffective disorder, and another serious mental illness that has psychotic disorder, psychosis as one of its symptoms. So for those who are not familiar, so schizophrenia is probably the largest group of these, and so the majority of people with serious mental illnesses like schizophrenia experience the first signs of their illness in adolescence or young adulthood. So usually by mid-20s, a person that's going to develop schizophrenia or schizoaffective disorder has already started to experience some of this. And we all know that we have a really fractured public mental health system. In Virginia, yes, we know that. Nationwide, it's the same problem. So there's often a long delay between the time that someone starts to experience symptoms and they actually are able to access consistent treatment. So early intervention, we're discovering, is really the key to addressing a lifetime of psychiatric disability for someone with a serious mental illness like schizophrenia. And so the interesting thing is that early intervention for schizophrenia, for example, has been going on overseas in Europe and Australia, in the United Kingdom for quite a number of years. But over here in the United States, we have been really slow to adopt this. It's been going on in some states, but really very limited early intervention services. And here in Virginia, I think our initiative is really the first early intervention program for schizophrenia and psychosis that I think that we've ever really had in the state. So just a little background, so worldwide it's pretty rare, 0.5 to 1.5% of the population, but despite the rarity of schizophrenia in particular, it's a really devastatingly costly disease. I mean, 25% of all hospital bed days, so that includes medical care as well as psychiatric inpatient care, 40% of all long-term care days in behavioral health, 25% of all Social Security disability benefit days have been attributed to people with schizophrenia. Estimates $65 billion cost the country a year in treatment and lost productivity revenue, tax revenue. And that doesn't even measure the impact to people that actually have schizophrenia and their families. I mean, it's a devastating diagnosis for people. So for youth that are experiencing their first episode, this is a terrifying thing. I mean, they've started experiencing potentially some psychosis. They don't understand what's happening to them. They can't exhibit this irrational behavior kind of comes with teenage years, right? I mean, I was there. But this is sort of an extreme situation because they don't really understand what's happening. They could have difficulties communicating with family, relating to people, authority figures, definitely problems with authority, substance use and abuse to mask their symptoms, to basically self-medicate. And so early intervention has been demonstrated in research now, over 20 years at least, to improve symptoms and functioning and help youth develop and learn and develop recovery skills. And so the goal is really to prevent that lifetime of mental health disability. And so my colleague Jeff Van Arnhem is here. He's the state level coordinator of our Assertive Community Treatment project or initiative. And so Assertive Community Treatment is basically it's a evidence-based practice, a team-focused evidence-based practice to address the needs of people with severe mental illness. Essentially, I called what we're doing ACT prevention because it hopefully will help youth to develop those skills so that they don't need assertive community treatment and other sort of more higher level services over a lifetime. So just to give you a sense, so we know that young people, especially of this age, the young adult transition age, they have high levels of mental health need, but they access services at a much lower level than other adult age groups. So this table is from a study that was done in Australia. So the green bar is the prevalence of mental health conditions amongst the various populations, and the blue bar is the extent to which they access services for their mental health conditions. So you can see that 16 to 24, they have a very high prevalence level, but very low participation level. And part of the challenge is that, at this age group, 16 to 25, youth are learning to be adults, they're learning to be independent. A lot of times what happens is kids may have mental health issues when they're children. Their parents have made them participate in services, but when they hit 18 and they're no longer under their parents' control, pretty much I can do what I want, you're not going to tell me what to do. Sometimes also what happens is, especially with this, with first episode psychosis, is sometimes kids can be away at school and experience their first episode when they're away from home, they're out of their natural support system. So we're finding that, here in VCU, there could be kids that are developing, psychosis, and we just don't know it because there's really no intervention for them. So, and here's just a recent study just published a couple of weeks ago in the Journal of Schizophrenia Bulletin, is an NIMH, National Institutes of Mental Health study of healthcare and morbidity outcomes for this population. Small study population, just over 1,300 people with commercial insurance that between ages 16 and 30 that had been diagnosed with psychotic illness for the first time. So they looked at 12-month mortality. So in the year following diagnosis, what happened to those folks that they were and it's a small study sample, but what it showed is pretty alarming. So 12-month mortality was 24 times greater in the age-matched than in the age-matched general population, 89 times greater than general population across all age groups. So basically the only age group that had higher mortality than these first episode psychosis folks was ages 70 and older. So that's it's pretty frightening. Now the challenge with this study is that it didn't look at the cause of death, so we don't know whether it was accidents or suicide, so we really don't know why they died. But the fact that they died at such higher rates is pretty alarming, and it really demonstrates the need for intervention. So in this case, 62% of them, at least one hospitalization or emergency room visit during that 12-month of the study. 61% filled no antipsychotic medication prescriptions, so they weren't probably getting any treatment. And 41% had gotten no individual psychotherapy. So they're really not seeing people to address this need. So it just kind of demonstrates the problem. So the concept here we're talking about is what happens over the course of time when a person has psychosis that's not addressed. So I said in the beginning, several years it can be several years before someone who is symptomatic actually accesses treatment. So, and we think that long-term recovery is impacted by the time period that they are experiencing symptoms and they're not getting treated. So they refer to this as duration of untreated psychosis, or DUP. So there's been a recent meta-analysis, and these are active links when you see the blue underline. So if you're interested in looking at the studies, when you get the PowerPoint slides of for the 2 days, you can click on the link and it'll go to the research. So this recent meta-analysis provided some real clear evidence of the benefit of early intervention. So people had much better outcomes over the long term. If they didn't receive services, they had worse outcomes. And then so the two potential mechanisms that we think are the contributing factors is the neurotoxicity of psychosis. So the more times a person experiences a psychotic episode, there's a longer term impact to the brain. So their neurological functioning, they lose neurological functioning. And then there's also the psychosocial toxicity. They lose their ability to relate to other people, to communicate with people. They become sort of, self-isolating, and in many cases they experience an increase in substance use or abuse. So some real issues there as well. So here's the background of what we're doing now, and to demonstrate the benefits of early intervention. In 2009, the National Institute of Mental Health funded a series of studies in localities. There were 17 studies, recovery after initial schizophrenia episode, ages 15 to 35, DSM-4 diagnoses with psychotic symptoms for at least 1 week and no more than 2 years since the identification of the initial symptoms. And what they did a randomized controlled trial first in 223 folks receiving the early treatment model, which I'm going to talk about, across as compared to people receiving treatment as usual. And they found that participants significantly more likely to experience an improvement in functioning. They stayed in school, they stayed in treatment, they took medication, improved their quality of life. And then there were 4 additional randomized controls trials of this model that included about 800 participants over the next couple of years. So these RAISE research studies became a new evidence-based practice, which is called coordinated specialty care. And it's specifically it's a team-focused model specifically for youth and transition age youth and adults with first episode psychosis. So this is a team-focused model, evidence-supported interventions, low-dose antipsychotic medication, low dose because these are young people. They're basically, psychotic medication virgins, if you want to use the term. Never taken an antipsychotic medication before, so you want to start, the idea is to start low and slow. Because we know that people who have been on antipsychotic medications for many years, they develop a lot of, there's side effects. There's, the older generation antipsychotics, they had tardive dyskinesia. Even the newer generation, people develop metabolic disorders, liver problems, high cholesterol, they gain weight. So, and what 18-year-old girl wants to gain weight? I mean, you can't keep people on medication if they have side effects like that. Cognitive and behavioral therapy, family education and support, very important, because a lot of times what happens with these young adults is because they're really suffering with their symptoms, sometimes their families, they disengage from family, their families don't understand what's happening to them, they may not have the internal capacity within the family to address a serious issue like this. So bringing the family back together, educating them about what's happening to the young person is really important. Peer support is a component of this, and also, of course, case management services. And the goal of this treatment is to provide recovery-focused, person-centered, culturally competent care. And they say that they refer to it as the care that weighs the duty to care with the dignity of risk. And so what that means essentially is, for service providers, it can be hard to pull back when you see a person you're working with that could potentially be making a bad choice. But we need to give young people who are transitioning to adulthood the ability to make their own decisions, to make those mistakes, and so basically it's the dignity of them making their own decisions and taking the risk that's going to affect their own lives. And so it really demonstrates, through the fact that they actually are engaged and continue to engage in treatment. This is a 2 to 3 year treatment process in this particular case. That this does help because it's made specifically for young adults. I mean, so the problem with our public mental health system, for those of you that work in this system, you know this, is that so many of our services, our long-term treatment services, skew so much older. I mean, an 18-year-old in a treatment group with a 45-year-old is really not a good match for that age range. So these are specifically focused on services that young adults will respond to. So I missed a slide, I think. Oh, so yeah, sorry, I missed this one. So one of the goals is to assertively outreach in the community and engage these folks, because these are treatment-resistant young people. They may have been in the mental health system, they want nothing to do with it, or some people, they don't think that anything's wrong with them. So getting out into the community, engaging with higher education, with high schools, with other entities where youth gather, creating safe spaces for youth to participate in services. So the clinical team is a team lead, usually a licensed clinician, primary clinician and therapist, a prescriber, whether it's a psychiatrist or a psychiatric nurse practitioner, a person that does outreach and recruitment. And then one of the important service components of this model is supported employment and education services. So a lot of people are familiar with supported employment services for folks with serious mental illness. It's sort of cultivating job opportunities, providing job coaching, supportive services for folks. Well, so this program does that, but they also provide supported education services. So it's a similar kind of service, but focused on the education environment. So this could be kids that dropped out of school, that they need to get back in school. They may need some help navigating the whole ADA aspect of, for example, you all that are in higher education, you know, we provide, yeah, am I 5 minutes? Thanks. You know, we offer, you know, the ability for folks to, you know, have reasonable accommodations in education. So the sort of support employment and education coordinator works with the youth, the family, if they so desire, if they want their family involved, and the employer or the education setting to help them get back into school or get to work. And then peer support. Peer support is really important. Now, one of the interesting things is there's a team here in Henrico County that provides this service, and the peer on their team is actually over 50 years old. And so when he was a PACT, a sort of community treatment peer on the Henrico ACT team, and when I heard that he had transitioned over to the young adult team, I was like, you know, 50 years old, but apparently, you know, he's really working with these young people and they've responded well to him. So sort of surprising, but some of the peers in some of these teams are young adults themselves. You know, they're in their 20s and they've had that experience of going through high school or going through college while they were dealing with mental illness. So it's very helpful to have that peer support. So with respect to what we're doing in the state, at the state level, so we have a coordinated specialty care initiative. Expansion of services to transition age youth and young adults was a recommendation of the Governor's School and Campus Safety Task Force. Governor McDonnell created that after the Sandy Hook incident back in December of 2012. And the task force recommended expanding services to this population. And so in 2014, the General Assembly allocated some ongoing revenue for this. We have $4 million a year in state revenue, about $1.3 million in federal that we're overseeing at the state level. And we have 8 community, who's familiar with community services boards? So most people. So the CSB, if you're not familiar with the community services boards or the CSBs, they're the primary point of entry into the public behavioral health and developmental services system. We have 40 CSBs that serve, you know, the entire state. And so we have 8 of them. We released a competitive application back in 2014 to identify providers that were interested in developing these services. So we have 4 in Northern Virginia: Alexandria, Fairfax, Prince William, and Loudoun. And then we have Henrico area here. In this area, we have Rappahannock-Rapidan Community Services Board, which is actually not on my list. I just realized. They serve the area, Orange County, Fauquier County, sort of central, north central Virginia. And then Western Tidewater, which is Suffolk, Franklin, Hampton, and Isle of Wight. So we're limited in how many services, how many programs we actually have. We do have some regional coverage in most of the main regions in the state. We'd like to get more money for this. So we've been doing this for 2 years now, and we're collecting data from these programs to track some outcomes. And so these are sort of the most important ones that we're looking at. So increased participation in employment or school, which is really important to, you know, get kids transition to adulthood. Hopefully they can become self-supporting, not need to rely on disability benefits. Decrease in criminal justice involvement. A lot of these kids are at risk of being involved with the criminal justice system. Homelessness. Decrease of use of emergency and crisis services. Improvement in social functioning, that's essential, you know, developing those recovery skills. Decreasing their symptoms, obviously, is important. Improving functioning, and we want to demonstrate that through their own self-report of whether they feel like they're achieving recovery. Satisfaction with services, and then increased family engagement. And so because this is, you know, we're looking at this from the youth's perspective, we've invited them to decide who is the family that they want to have involved. It may not be their family of origin, because sometimes families of origin are problematic. It could be friends, it could be other family members, it could be their significant other if they have one. So we're in the early stages of this. It's only been a couple of years. But we're really proud of having gotten this going at the state. I mean, we've got a lot more resources in this project than some of the other states have, so we're looking forward to positive things. And so if you have any questions, here's my contact information. Feel free to call or email. And then the link at the bottom, as I said, these are active links in the document. That's the website, on our website, where we have, you know, who's providing these services and a little bit more about them. So, and I guess we're going to take questions at the end, right? Okay, thank you.